Welcome everybody, I'm Becky George, Chair of HINS, clinical informatician, occupational therapist by background, and an avid fan of ensuring that we get regular updates with what's going on inside the ministry. And so I'd just like to welcome you all with us tonight. Ruth has asked me to do the intro, but I'm just going to get Ruth and Darren to introduce themselves, and then I'll launch into my introductory spiel. So Ruth, over to you.
Kia ora everyone, I'm Dr. Ruth Large. I'm an emergency physician and rural hospitalist. I work for the Waikato DHB and I'm the chair of the New Zealand Telehealth Leadership Group.
And kia ora everyone, Darren Douglas, General Manager of Digital Strategy and Investment at the Ministry of Health, and also leading out on the National Health Information Platform business case.
Wonderful, thanks guys. We're at a nice tight-knit panel this evening, and I'm just going to give a wee bit of a briefing that was sent out to you a little bit earlier in an email. Tonight you're here to have an update on the National Health Information Platform. And on the 2nd of September 2019, Cabinet approved the development of a business case for the National Health Information Platform. And this is going to improve access to and use of health information as a key enabler of an effective and sustainable health and disability system. The ministry engaged with the sector and other agencies to develop a programme business case, and that was scheduled for Cabinet review in March 2020. The programme case proposed a phased delivery approach over 4 tranches, with investment linked to the delivery of value. The abbreviated name for our national platform is nHIP, and nHIP was supported as a key enabler of the Health and Disability System Review, and certainly meets a number of the key recommendations. But then COVID-19 happened. So tonight's an opportunity to welcome you all, to welcome Darren and thank him very much for joining us this evening so that he can provide an update on the status of where we're at and what to expect next. So Darren, over to you.
Thanks, Becky. Thanks for the fantastic introduction. So let me just quickly share my screen. Okay, so I'm going to run through a bit of an overview of a bit of context around what the National Health Information Platform is. I'll run through a reminder of where we got to up until March, and then I'll give you an update on status and the path forward, and then look forward to discussion and questions following that. So a reminder, I guess, just to kick off of why we're doing this, and we're doing this for a whole range of different stakeholders, for consumers, whānau, clinicians, policymakers, and we're doing this because we really want to use data and use digital to optimise our digital health services and really contribute to equity and contribute to improved outcomes. And we think about technology in a pretty broad sense, and not in terms of technology itself, but in terms of how can we make sure it improves equity? How can we make sure it puts consumers and whānau at the centre of our care? How can we use data to give us insights into how we can improve? And importantly, how can we use data and digital to deliver care differently rather than just digitising the way that we work today? And so about 2 years ago, we worked on the formation of the Digital Health Strategic Framework. And there's a really simple premise behind this framework, and that is that the public health system is a complex adaptive system. And what that means is that there are multiple participants, and the interactions between those participants mean that that ecosystem is never static and it's always changing. So when you try to impose specific technology solutions on that ecosystem, they have a habit of not either breaking, or they have a habit of people trying to avoid them, or in the worst case, they have a habit of getting in the way of clinicians doing what clinicians need to do, or consumers engaging in their own care. So we tend to avoid that, and rather than look at what originally started out as a national electronic health system, we think of some strategic objectives that we're trying to support. And rather than try to plot out a detailed roadmap to those over 4, 5, 6 years, we try to measure our progress towards these objectives so that we're on the right trajectory, but we're not too directive about the steps we need to take to get there. Because in that ecosystem, that environment is always changing. So we need to remain responsive and agile to respond to the changes in that environment. And the question that begs is, if you're not going to determine from the centre what clinical system or what patient portal or what particular administration system you're going to use, then what do you do? And we think about a series of enablers. So we think about interoperability. How do we make data accessible to everyone that should have a right to access it? How do we use standards to make sure that that data is standardized and consistent when we bring it together? And how do we have a common architectural framework so that all of those participants, whether they are small NGOs or large DHBs or policy makers or consumers and their circle of care, how do we make sure that everyone understands how they can coexist and fit within that environment? We also think about security, privacy, and trust. So how can we build and maintain social license so that citizens and users of the public health system have confidence that we are using their data appropriately, that we're looking after their information, and that we have their best interests at heart? To do that, you do need some foundation services. So while we may not select solutions from the centre, we certainly think of technology enablers that will help that ecosystem to function and to be optimised. And these are things like the National Health Index. They might be things like a digital identity. They might be things like a terminology service. So some of these things that are then able to be used by everyone that's interacting in that ecosystem. And then we've got non-technology considerations. So our procurement processes are anything but digital today. So how do we do something about that? Our approval processes are fairly torturous. I know that well, given the organisation I'm in. And the way we innovate is not particularly optimised. So we have lots of good ideas and we have lots of pilots and proof of concepts, but they don't necessarily scale. We don't necessarily have visibility of what is happening at a whole of system level, what's working, how do we learn from the things that haven't worked. So this is where we believe the Ministry of Health should focus, rather than focusing on individual solutions, whether they be clinical or consumer or administrative. And another bit of context is that we know we've got lots of data. We don't have a shortage of data. The problem we have is that it's not joined up. It's fragmented. It's locked up in different silos, different organisations, different technologies. You can't always get to it. And even when you do, it's not standardised. So when you try to bring it together, often it's really hard to get a cohesive picture of what that data is telling you. We certainly don't use that data to advantage people, whether those people are clinicians or policymakers or consumers themselves. And because our data tends to be anchored in organisations, while we may manage the data within an organisational context, when we make it accessible outside of that organisation, we have a long way to go in terms of our data governance and our understanding around data sovereignty and our understanding around privacy and social licence. So we've got a lot to do in this space. The Health and Disability System Review called out this as an issue. It certainly highlighted digital as a major enabler of system transformation, and it specifically called out the National Health Information Platform as one of the mechanisms that was important to get us there. So we think about an analogy of a GPS or a map application on your phone, and just bear with me with this one because it does start to make sense. So if you go to a strange city, and some of you will notice the strange city in this instance is Hamilton. If you go to a strange city, you will hire a car. It might have a GPS in it, or you might use the app on your phone. You can enter where you want to go, and the app or the GPS will calculate the fastest route to get there. It'll suggest alternate routes, and it might adjust that based on traffic conditions as you're traveling. It'll give you useful information about your journey. So how fast can you go? Where are the petrol stations? Where are the hotels? And it will constantly adjust your time of arrival. The interesting thing about that example is that the user experience that you're getting there was created using data that is not centralized. It typically wasn't created to provide that user experience. It's been leveraged to deliver it. And the user experience you get can be personalized. So you may use an app on your phone that is different to the app that someone else is using. It uses the same data, it performs the same function, but you might personalize it so that Billy Connolly is giving you directions and someone else wants it in Te Reo. I mean, you can do all of that. So it's a really nice, seamless user experience to the extent that we don't even think about it. It just happens. And when we started this journey of thinking about the National Health Information Platform, we spent quite a bit of time, this is about 2.5, 3 years ago now, we spent quite a bit of time on personas and customer journey, really trying to understand pain points and opportunities around access to data. So putting aside the applications that people used and really focusing in on what were their pain points as they were going through that journey, whether they were a young mother with a child, or whether they were someone in a rural community or elderly. What was their experience, and then what might the future look like if we address some of those pain points. And the aim of this is to try to create that GPS experience in health. So if we can surface data safely, securely, and we can make it accessible in a way that is able to be consumed by multiple applications that suit the user experience that an individual wants, and we give people choice, then we might have someone that wants a reminder of their events on a wearable. We might want to look at a health record and interact with it. We might have telehealth virtual consults. We might have a cohort of individuals on a register so that we can look at that cohort from a population point of view and look at clinical safety and interventions. We might have recovery and wraparound support services, and we might actually be able to measure patient experience and patient outcomes. If we could open up the data, then all of that's possible, and we could get an experience a bit like the GPS. So we think about our objectives as being multi-pronged, really. We're interested in innovation. We're interested in how can data support innovation. We're interested certainly about the individual and their whānau and their community. So how can data enable people to become more active in their own health and well-being? And how can it support communities that are supporting people to live better lives? And particularly from an equity point of view, how can we target services at those that are most vulnerable or disadvantaged today? We do want to focus on clinical process and improve the lives of clinicians. So whether that is more accurate data for decision making, or whether it is enabling tools to support workflow across organisations, care coordination, all of those things are important as well. And we want to get value and insights out of the data, so policy, research, strategy. nHIP's trying to do all of this. And many of you will have seen this diagram before, and it still remains current. So in really simple terms, the premise of nHIP is that it's taking that enabling layer in the digital health strategic framework, and it is using that layer to make data accessible across multiple data sources in a way that's safe, secure, and trusted. So we don't believe that we need all of our data in a single data repository. And just like that GPS experience, we can surface data from multiple places, and we can then integrate that and make it available in a standardized way to those range of stakeholders. So we can do that and make it available in the right context. We can make it available through multiple services and tools, whether they're wearables or smartphones or desktops. We can make it available to multiple stakeholders, and we can deliver that in partnership with the sector and with industry. So what we're proposing with nHIP is not a proposal of a big program sitting in the Ministry of Health or in Wellington, building a lot of stuff and then trying to convince people to use it. We see the data sources being in multiple places, a lot of those in the sector. We see the services being delivered coming out of industry and coming out of the sector as well as out of the centre. And ultimately, one of our premises here is that we want consumers to be in control of their information. So in February, we completed the program business case, and we put a health report and a cabinet paper up through the Minister's office. And this was the proposal that we put in place for our first tranche. And I won't go through the detail now, but in general terms, we thought about enablers that we needed. We thought about data that we wanted to make accessible. We thought about how we would get existing sector systems to adopt those services. So how do you make a GP practice management system integrate in with your trusted national source of medicines data, for example? We needed to provide the data service, so to make that data available in a safe way. And we then really wanted to target sector exemplars. So how could we look at communities, or how could we look at organisations that could do some really smart, innovative stuff with these new capabilities? And our delivery plan was, back in February, was that we were seeking cabinet approval of the program business case in March, and we had a budget bid that was looking for a commencement of tranche 1 of the program in July this year. And a simple architecture view of the capabilities that we were delivering shows that a lot of the capabilities supporting the delivery of this were being targeted in tranche 1, not surprisingly. Some of those foundation services for tranche 1 we were deferring to later tranches simply because of the complexity of delivering those. But we were delivering data through APIs out into the sector. And then unfortunately COVID happened. So March was not a good time to be trying to get a cabinet paper up to cabinet. And not surprisingly, that cabinet paper and our program business case approval was deferred. A little more on where that's taken us to in a second. But a bit about COVID and the experience, because while COVID disrupted progress around the National Health Information Platform, it also taught us a lot and created capabilities that we could leverage. The first thing about COVID is that we focus really strongly on how do we decide what technology from the Ministry of Health to deliver. And there were 4 criteria, I guess, that we looked at. One was it had to improve public health. We had a lot of proposals and a lot of offers of assistance for things that were great, but actually didn't really get to the core of what was most important for public health at that time. We had to put privacy at the centre. So in everything we did, we made sure that there was a really close focus on privacy, engagement with the Office of the Privacy Commissioner, ensuring that data was accessed appropriately, and importantly, that we could give the public confidence of that. But we recognised that we also needed to balance the health needs with the non-health needs. In the COVID context, that was all about people's movements, the economy, getting out of lockdown, and there were other considerations rather than just the health ones. And then lastly, we focused on those things we could actually deliver. We had to deliver really fast, so we didn't have the luxury of doing exhaustive analysis and looking at options of technology and writing business cases. So we really picked the things that we knew we could deliver and would work. And what that meant was an acceleration of telehealth. And this was clearly not done by the ministry, this was done by all of you, by the sector. Dramatic uplift, and telehealth uplift was really based on solutions that were already in the sector and were already in use. It was really applying them in ways that we hadn't before. We leveraged cloud heavily. 5 years ago, we couldn't have responded to COVID in the way that we did because those cloud services just weren't there, they weren't mature enough. We stood up, for example, the National Contact Tracing Service platform. We stood that up in, I think it was about 4 weeks. We could not have done that 5 years ago. The COVID Tracer app, which now has about 2.3 million registered users, we've now delivered 4 major releases of that over the period of about 5 months. Again, 5 years ago, we couldn't have done that. And I'll remind you that this is the Ministry of Health we're talking about, and if we can do it, believe me, lots of others can do it better than us. We use collaboration tools a lot. So experiences like this, ways of remote working, I can remember pre-COVID being told and pressured to justify a trip to Hamilton for a workshop, which will remain nameless, but absolutely told that there is no way that you could do this remotely. We needed all these people to converge on Hamilton because they all had to be in the same room to do a workshop. Fast forward 2 weeks and that workshop happened, but everyone was remote and it worked. It was fine. So we're used to collaborating and remote working now. I've talked about digital channels. We created both a consumer and a health professional digital channel very, very quickly as a result of COVID and the public health platform. And really the way that we did this, it reinforced the importance of those strategic enablers. So data standards were really important in terms of getting data and being able to make sense of it. Digital identity and security were really, really important in terms of how we did this. So it gave us a new confidence that we could actually deliver these things, which as you go into the nHIP world is really, really important. And I won't go through the detail of this, but there's a couple of slides here on, so what capabilities did we actually deliver? And what does that mean for nHIP? So our digital channels, both the consumer and the health professional channels, while they won't be directly applicable to nHIP, what sits underneath those is a service delivery model, an understanding around data events and analytics, an understanding on how you register and onboard users to those sorts of apps, a real understanding around accessibility and equity assessments and how you factor those into a backlog and a roadmap of items. Really important things as we go into nHIP. Privacy and data governance. I've talked about putting the consumer at the centre and privacy at the centre. We did privacy impact assessments. We engaged with Office of the Privacy Commissioner. Again, really, really important things and really great learnings. The sector did a lot around data acquisition and accessibility. I've never seen so many dashboards in my life. I mean, they popped up all over the place and they were really, really important. We ramped up our security capability in the ministry in terms of incident and event monitoring and our operations centre capability. And we really had to learn fast around how you operationally support these digital channels and these APIs in a way that we hadn't previously. We have a sector that's now far more digitally enabled. So while we've seen a drop off in teleconsults, for example, the use of NZEPS and digital e-prescriptions is still really high, and I don't expect that to drop back. And we've done a lot of work, and this is still in progress, around digital identity. So for nHIP, in the program case, our tranche 1 proposal was to create a digital identity that was able to be bound to an NHI or to a health practitioner number. And we were able to look at how we did that, and we're currently working on that now. So we will have a consumer and a health provider digital identity with NHI and HPI details bound that then enables those to be a verified identity to be used by nHIP. We've also done a lot of work around our API marketplace and developer portal. So we are in the process of establishing those now, again, leveraging off of that COVID experience. And we've done a lot of work around a certification process, because one of the interesting things around how we certify users at the moment of the National Health Index, for example. So rule number 1, you need to be a DHB or a GP practice. That's the only way you get in. And rule number 2, every organisation and every vendor that comes to us has to go through the entire process again. When you roll forward into an nHIP world, if we have an innovative product in the market that wants to integrate with these services to do great things with it, we can't put organisations through a very long-winded, laborious certification process. We need to be nimble, but we need the certification to maintain security, privacy, trust of the data. And the other good news, lastly, is that we're working on the immunisation system. So COVID has clearly given that a bit of a nudge, but the approval is to replace the NIR and to really deliver an immunisation platform that makes immunisation data accessible in all the places that it needs to be. So that is currently being established at the moment. So where does that leave us? We're resuming the National Health Information Platform. So we got agreement back in April. Once we knew we weren't getting to Cabinet, Minister of Health agreed that he would seek Cabinet endorsement of the PBC later this year. This may slip into early next year, but we're still currently targeting December, although whether we can get on the Cabinet agenda remains to be seen. We also got, though, Minister of Finance and Minister of Health approval that we could proceed with the development of our tranche 1 case, and funding was allocated to allow us to do that. When COVID hit, the entire nHIP team was shifted, literally in the space of a weekend, was shifted onto the COVID response. We only started to get people back onto nHIP in August. So we're now in catch-up mode, I guess, in terms of that team developing a business case, taken those COVID learnings and updated our program case, and looking at engagement, of which this is the start, and further discovery around proof of concepts and prototypes. The couple of outputs from this is we now see nHIP as more of a portfolio of investments. We don't believe that we need to go to cabinet looking for all the money to do nHIP, because all of the investments being made in the sector, if they can be aligned to that nHIP architecture, will be able to make a contribution. But we are also developing that tranche 1 business case, because clearly we need investment to get us going. A little bit around our problem statement. So one of the approaches we're taking is that we've got 6 problem statements, and these will be added to. We're using these to try to understand where we might want to focus for tranche 1 in terms of impact. And we're using this double diamond methodology, working with service design team at DIA and with some sector organisations to really explore the problem definition, the discovery around what a solution might look like, and then proof of concepts and prototyping to really inform our investment case. And these are our 6 problem statements. As I say, these will be added to, but we think these are quite nice in that they're very specific, but they force us to think about, are we investing in the right things as part of tranche 1? So firstly, we think people should be able to update their own details on the NHI. Seems like a bit of a no-brainer, but today you can't. We think that any health professional should be able to access the core record for a person in their care. And if you're a clinician within a DHB or a hospital, or you're a GP, or you work for a large NGO, you probably have this today. If you work for a small NGO, then you will quite often have 0 access. So we believe that this is a problem that needs to be solved. Of course, once you provide access to a person's record outside of those organisational constructs, you now really need to think about consent and permissions around that access. So that has to be baked into that problem as well. We really want to solve medicines. So we've got pretty good access now to community medicines, GP prescriptions and community dispensing. We want to get the medicines change list out of on discharge, and we want to incorporate that into a medicines data repository so that we can make that accessible. We're also working on outpatient scripts being integrated in with NZEPS, and that will also add that data. So we think that's a problem worth solving as part of tranche 1. We want to understand more about patient engagement, particularly around people with chronic conditions. And we're working or starting the process of talking to Counties Manukau around how we might do that, focused on diabetes. Again, we think if nHIP just focuses on making data available and we don't understand the complexity of individuals' experience of the health system, then we will probably not solve some of those really important problems. Number 5 is really just encapsulating the premise of nHIP. If you bring data together from multiple places and try to deliver that user experience like the GPS, what does that look like, and what do you need to consider to do that well? Because if you don't do it well, you're simply going to just dump a whole lot of data on people. It won't be understandable, it won't be useful. We need to understand more around that as a problem. And we also think that everyone should be able to see their eligibility and entitlements, and their care providers as well. So we really want to think about entitlements and eligibility, whether it's community services card or travel assistance or pharmacy subsidy card. This is difficult because those are all delivered by different organisations and are scattered. So we really want to try and bring that together. And where that leads to is that helps to inform what we now think tranche 1 looks like. So we still think about a data service, which is consistent with the thinking of February. We think about these consumer and provider services, which again is consistent. And we think about change and adoption. So this isn't a build it and they will come program. We need these services used, and what do we need to do to make that happen, whether it's funding or capability or other incentives, policy or commissioning changes. And we now represent our tranche 1 scope like this. So we have work streams, and then we have projects within those work streams. So our governance and assurance is what you would expect to see for a program. Our data service is where we aggregate access to these different data sources. And in line with those problem statements, we believe that medicines, demographics, entitlements, and primary care are probably a good place to start. Immunisations, because of that immunisations program, will certainly come into the fold in tranche 1, and we think we're pretty close on laboratory information as well. So we see that as probably another area to focus on from a data point of view. We then want to stand up a universal consumer service and a universal provider service. So this is not to compete with the market, but this is to recognise that today not all New Zealanders have access to their own health record. If they're not enrolled with a GP, or they're enrolled with a GP who doesn't offer a patient portal, they have very limited access to their own health information. So we believe that creating a universal service, the MAPS app on your phone maybe as an analogy, we believe that that's an important step to enable everyone to at least get to their core health record. We similarly believe, as I've said, for small NGOs and other health professionals who should have access to a core health record for someone in their care, they similarly need a channel to be able to do that. We then have enablers, and these haven't changed a lot from February, except with the addition of identity, and that's leveraging off of that COVID experience. So we want to create a consumer digital identity and a provider digital identity. We need those for those universal consumer and provider services. But once they're created, we then have an identity that an individual can hold with attributes that can then be used by other organisations who want to be able to trust that to access services. That identity will also accept existing trusted verified sources. So if you have a RealMe account, for example, we will aim to enable you to use that RealMe login to access these services. And then change and adoption is really important. Again, we don't want to build it and hope people will use it. So we've got a real focus around service adoption. How do we make sure these services are actually used in the systems that are in play in the sector today? How do we think about, again, those exemplars? How do we look at innovation? How do we look at how we can incentivize and support that? And then lastly, those enablers like standards, policy, digital literacy, digital inclusion. How do we make sure we target those and have those in place as well? And our delivery plan, unfortunately, has effectively slipped 12 months. So we're now targeting budget 21 rather than budget 20, and we're now targeting a July 21 start. The good news is, because of the COVID experience, one, we have a bit of a head start. So we now think our tranche 1 will be delivered in a shorter time frame. But secondly, we also think, if we look at that simple architecture view, that the yellow dots with the bold outline are those things that are new from the tranche 1 that we thought we were going to deliver in February. So we have some additional data sources, we have digital health identity, we have consent, and we have terminology services are now part of the scope. And we will be creating those consumer channels, both health consumer and health provider channels. And that's just a bit more detail on the time frame. In terms of advisory and governance, we have re-established our governance structure, and that is what you would expect to see from a formal program governance structure. But we've thought carefully around engagement and advisory as well. And one of the things we've decided to do is really try to leverage existing groups. So groups like Telehealth Leadership Group, KILN, nHIP, consumer groups through HQSC, really looking at how do we leverage those existing groups rather than trying to form a new group. And I guess that partly reflects the experience from the program case development, where the reality is we are still at business case stage. So we have to be careful that we don't put structures in place that sort of start and then stop again. So we're very, very aware of that. We do see, though, these expert working groups being quite important underpinning the project team. So as we focus on those specific problem statements, let's take medicines as an example, how do we get the experts around that medicines domain to help us and advise on what the problems really are and what the solutions could be? So what happens next? We have the program team back in place. We are starting our engagement process. So we've been very quiet for sort of 6-7 months. We're now going to get a little more noisy and hopefully keep everyone informed. And as I've said, our engagement will be through existing groups. And as long as that's effective, then I don't anticipate that changing. We are planning market engagement. So an EOI, or sorry, RFI will go out to the market either tomorrow or Monday. And that will be looking for information from the market around some of those key capabilities, like the consumer service, the provider service, like our integration and record location services, looking for experience in the market that goes, well, actually, these solutions are already there. So here's the choices we might have, or here's the functionality that's really important. Here's what's worked. Here's what hasn't worked. So we really want to tap into the market and learn from their experience, and obviously tap into the sector as well. And this is all helping to inform that tranche 1 investment case. So we have a gateway review planned for 2nd week of February, and then we're targeting cabinet with the investment case in March. That's our time frame. I'm happy to be contacted, or there's a digital health email address which the team monitors. So really happy to be engaged and answer questions or meet with people. So what I'll do is I'll stop the screen share there, and then it'd be great to have some questions and discussion.
Awesome. Oh, Darren, thank you so much. Incredibly comprehensive, because you've taken us from where we knew you had been right through to where we can see you're heading next. And so it's given us a very clear idea of both context, concept, and then future intention. And those problem statements are incredibly helpful to identify your focus areas at this time. I'm just going to hand over to Ruth, because she's been monitoring the questions. So Ruth, do you want to kick off?
Yeah, look, Darren, I think I should start by saying thank you to you and your team. And I know I did this post or during the COVID period, but I think you've highlighted that really nicely about how well your team have done. And I think there are many of us who would have had doubts about that before. The track record hasn't been as great. And it just does go to show that when you take those brakes off, that things can go ahead. So there's questions seem to be falling into two broad themes: data and collaboration. But maybe just preempting some of those, I'm interested in how you're going to have this portfolio approach, which I entirely get, and all of these things are going to interact together. But how are we going to sort of measure success and start ticking things off, and in order to be able to prioritise what comes next? Have you got a sense as to how that will happen?
Yeah, I do. A bit like that ecosystem sort of intro, that we're trying to not be overly prescriptive and to make sure we've got the right structures around how those decisions are made. So there's some really important work happening at the moment, led out of the DHB CIOs with the ministry, around understanding a bit of a 10-year roadmap of investment. Because one of our constraints is we know our health organisations, whether they're district health boards or GP practices or NGOs, we know they're underinvested around digital enablers and technology. And when we create something like nHIP and make data accessible, that doesn't automatically mean that the systems that are used within health provider organisations are actually able to consume those services. So the first thing is that 10-year roadmap is really important, and we're working closely with the CIOs on that to try to prioritise the capabilities, so that where those investments are made, they are made to deliver solutions that are then able to integrate with those nHIP delivered services. Importantly, from a Treasury point of view, that's incredibly important as well, because one of the first things Treasury will always ask is, how does this investment differ from that investment? So we need to be really clear we understand that we're not duplicating investment, but similarly that we're not leaving gaps. So that's the first part of the answer, is we are looking at that 10-year roadmap around DHB investment predominantly, but the engagement's also stretching out into primary care. The second part is that we, as a ministry, have other investments like that immunisations investment. So we have said to the immunisation program, and Peter Marks, who heads up my architecture team, effectively sits across all of these, which is quite convenient. So we've said to the immunisation program, you will create an immunisation repository of data that is disaggregated from the applications that use that data, and you will put FHIR APIs on the top of it. So the good news is that nHIP doesn't need to do that. What we need to do is to enable those FHIR APIs to then be available, and to be able to understand how the sector really wants to adopt them, in use cases that the immunisation program itself won't pick up. So ministry investment also being aligned is important. And then the gap around those portfolio decisions really comes down then, I think, to the existing groups we have. We have the digital enablement oversight group that has just been formed. And I think groups like that become really important because we've got investment going into telehealth or digital inclusion, and access to information and data will be one of the major enablers for those. So having visibility of nHIP investment into groups like that telehealth oversight group, into groups like the DHB CIO leaders group, into the ministry finance functions as they make decisions, I think is the way we manage it. The nHIP program governance will have visibility of that because ultimately they govern where the nHIP investment's going. But I think my sense is that's a practical way of doing it. If we tried to form sort of an Uber portfolio governance board for the sector, it would collapse under its own weight.
Oh, thanks, Darren. That's really great. And I wonder whether we can morph now into data. And I'm going to try and combine some of these questions together. There's quite a few questions here about governance, and also I'm getting a sense that people are also asking about data sovereignty. Can you maybe just talk a little bit about those two things and how they'll work with nHIP?
Yeah, I can, although I would profess that we don't have the answers in this area. So if I take sovereignty first, I mean, I think sovereignty is really a case of ensuring that we engage with iwi, with Māori up front in the conversations around nHIP data and how it's used. We tend to think of data sovereignty as should the data be offshore? And to be honest, our view is that if you engage up front, honestly and transparently around what the data is, how it will be used, how we will protect it, how we will make sure it's accessible to everyone that should have a right to access it, including whānau and iwi and Māori collectively, then I think the data sovereignty conclusions will be the right ones, whatever they are, and I don't know what they will be. The question of data governance, we are currently working on, or Simon Ross, who is in the ministry team, is developing the data and information strategy currently. And that's really important because that question of how do you take data governance out of an organisational construct and apply it across federated data in a consistent and safe way is something that needs really close attention. So I don't have the answer to that. What I can say is if I look at the ministry, our data governance in the ministry around sector data sets tends to focus on data sharing, which is interesting. So it doesn't focus on data assets and how those data assets can be leveraged. It focuses on discrete requests of should organisation A have access to this data set for this purpose? And it's a yes or a no with maybe some conditions, and then 6 months later a different organisation will have a request for the same data, and there'll be another process that then answers whether that can be shared or not. So I think to me data governance is an area that needs huge attention, and if we put the individual at the centre of that, nothing will undermine public trust and confidence than people using data inappropriately.
Yeah, absolutely. And I think that often that does segue in with a couple of the other questions that we've had around need to look into the legalities of it in terms of entities, in terms of legal advice and an understanding around how we truly set out to identify that path for sharing and not come across some really obvious stumbling blocks too late, and ensure that we get that pathway right. And
there'll be lots of people listening in that know a lot more about that than I do, certainly. And the thing I would say is it's a problem we have now. This is not a problem that will be created by nHIP. hopefully nHIP is going to need to solve it. Otherwise, otherwise it won't be effective.
Mm-hmm. One of your problem statements was obviously around what I conceive as the expert patient. So the ability to really engage with those consumers who are managing chronic conditions in the community, who are living a situation that is mostly unfortunate, but gives incredibly valuable insight into how they want to navigate and interact with their information and the health service, health and disability service at wide. And I think there is that notion of expert patient. And I'm just sort of wondering, you're obviously engaging with DHBs around that already. Do you have any concept of where that's going to go? Are they going to lead off into a certain or specific outcome, or are you looking at to provide a framework for engagement with those types of groups going forward as well?
Yeah, good question. And so in terms of where we are now, really, we're right at the beginning. So of those problem statements, probably the one that's least advanced is that patient engagement chronic condition space. The interviews we've done, and we've done about 30 interviews with groups or consumers, and a really a high number of those looking at equity and Māori. And the interesting thing for me is that, we're taking the time, and I think quite rightly, just to understand the problems, because the problems in my mind, in terms of benefits delivery, maybe it's not expert patients we focus on. Maybe it's rural communities. Maybe it's just understanding how you make just basic data available to people that are making these decisions day in, day out.
But there's going to be a continuum of those who are really wanting to be engaged with those who kind of only want to touch base now and again and yeah, out of necessity. Because it's interesting that you're engaging with DHBs when in fact what occurs to me, having worked in that scope, is to actually go, what about the organizations, what about the MS Society, what about the associations of actually quite driven, articulate consumers who are well engaged and able to provide that information. And I would say, look wider to that breadth of social group and association construct that would then enable you to engage directly with consumers. Yeah,
good call. I mean, we have, it was probably just my language. I mean, we're certainly not just engaging with DHBs, but to your point, I think, yeah, there are lots of other organisations that work day in, day out in the space that we should be engaging with. So good call.
Cool. Ruth, over to you.
Thanks, Becky. We've got lots of questions here. We might actually get Darren to give us some offline questions and post them, I think, with the video, so we won't lose these questions. But what I'd like to just move away from data for a minute, Darren, and just maybe ask you about collaboration and capability. So there's a few comments here, some of them about, hey, how can I get involved if I'm a developer? How does this fit in? Is it always going to be the big fish who catches the bait? And the other question, which is sort of a morph to that, is about capability. And one I notice here is particularly about building FHIR APIs. It's new to the sector. How are we going to build some of the capability? And that obviously won't be the only new thing to the sector. So just a little bit about collaboration and capability.
Yeah, I think I mean the stage we're at is sort of reflects my answer to this, but we're at investment case stage, and what we're really trying to understand at the moment is what are the problems and what are the benefits that would flow if we solve them. So how do we present a compelling case effectively to the investor to say this is worth investing in. As I say, we think we know what the key focus areas will be in terms of data access and digital channels and some of those enablers. What we're about to do is go out to the market, as I say, and really get information to help inform our investment case around the approach and the costings that we apply into the case. So, from an engagement point of view, I'm keen to engage with people around this now to get insights and to understand what the opportunities might be. But we need to be cautious that we are still at investment case stage, and and there's a level of detail that we just won't know, and we don't need to know right now. When we go forward, one of the things we are absolutely focused on in that tranche 1 scope is, as I say, is around certification. And if I think about fire APIs, yeah, they're new and there's limited capability, but it's growing pretty fast. I think HL7 New Zealand did a great job of really trying to build knowledge and understanding in the workforce. Our focus around certification is to be able to create a developer portal that provides test harnesses and provides good documentation around the data that's accessible, and enables anyone really that meets the right criteria to get in there and actually start to develop capability or use the APIs that are there to develop solutions. So our focus is on making this as open as possible, with the caveat that everything we do needs to ensure that we've got that privacy, security, trust. We were interested, a little bit of a departure, I guess. I was interested to understand how IRD have done this, for example, because they have APIs and they make their data accessible. And the one thing that struck me as a real difference between IRD and health is that I asked IRD what happened, how do they onboard users of their APIs, and how do they ensure that those organizations were using the data correctly. And it was interesting that they put a lot of focus on due diligence around the organizations, but once the organization was in and was accessing the APIs, the IRD approach was simply have a contract that says that we commercially are contracting that you won't misuse the data, and that was it. They were done. Now, in a health context, I personally don't think that's good enough. I mean, I just think we need far more assurance around how this data is being used and how we can give health consumers confidence that the data isn't just going to places it can't be, because it only takes one publicized misadventure and you have a real problem. I'm not sure that answered your question, Ruth, really, but
no, I think you did. Thank you. That was good. I'll leave one for Becky.
And please do come through, as I say, to that digital health email address if you really want to make contact with us and have a chat or provide some input. Please do.
Awesome. Yes, I think there was I'm just looking for it. Right. Has there been any thought put into how to reduce the inflow into the health system by upskilling consumers to manage their own health more effectively at home?
Yeah, so in that change and adoption work stream that I showed, sort of the last one on the right, it's where we have the literacy and inclusion initiative, and really thinking and to be honest, really working with others that are in this space. I mean, if I think about literacy and inclusion in communities, there are Maori NGOs and there are community groups who understand what the barriers are to their populations and their communities far better than I'd suggest most of us would. So I think we certainly have put thinking into it, and the one thing I can assure everyone is that in the business case, we will have investment targeted at how can we address that potential barrier for some communities. I mean, it's not going to be let's give everyone fibre and buy everyone a smartphone, and let's get everyone through online learning, but it will be sufficient to enable us to work with organisations who are in this space to really focus on communities where this is a barrier and where it can make a real impact.
And I think that's a two-pronged attack. So I'm going to say that, it's not only consumers, it's also workforce around that digital literacy. But I remember having a conversation with you, Darren, about consumers and actually saying, wouldn't it be incredible to get a significant proportion of our population knowing the NHI off by heart? And to be able to do that. Yeah, absolutely. It's an incredibly audacious kind of goal, but, at the end of the day, we've seen the evidence in the recent COVID response that actually that's incredibly precious entity and informational element. And this is what we're going forward, that digital identity and going forward is really key. So yeah, it's a thought that's out there.
I think your point there, and I'll just give you an eye on time, but really quick response to that as well, is that the the digital literacy part of this, or the health literacy part of this, doesn't, you know, as you say, it can be as simple as what's the nHI, and just lifting people's awareness of that is a big gain.
Yeah, and yeah, it's a kind of a, you know, we've really got to be quite shrewd about how we do the comms and how we do our engagement process around that. Ruth, we've got 4 minutes left. If we've got time for one more quick question.
Look, I'm going to ask one just about, again, in the collaboration space, because the ministry is quite well known, and you put that through in terms of working in silos, but also I think across our government we have difficulty, with our social agencies and sharing of data. So there's a question in there about how are we going to tackle this issue of making sure that the data that's important to me and relevant to me as a patient or me as a provider is across the sector. Have you got a feel for that?
Well, it's certainly one of the key objectives around nHIP. You know, that sort of data diagram, that when I said, you know, consumer generated data and health data and social data was very deliberate. I think the reality is, though, that it's going to be easier to make health data accessible within a health context first, and some of those broader agency data sets or data use cases are going to be a little more difficult. But once the enablers are there and we have health data more accessible, then I think they'll be absolutely, particularly with communities who are going to be saying, well, actually health data is fine, but actually I really want to access this other data, and why can't I do it? That the digital health identity will not differentiate. So if we make that digital health identity available with attributes, there is no reason why that couldn't be picked up by other agencies or by other organisations and be used to start to bring that data together.
Yeah, it's the ability of being able to, as we talk about it, elicit behaviour, elicit the drive and momentum going forward with how we start off this process. We've got 2 minutes left. We've got some wonderful comments thanking you. Quick question: what's the difference between New Zealand's approach and the My Health record in Australia?
So the My Health record in Australia, in sort of 30 seconds, the My Health record in Australia started from a philosophy where our National Electronic Health Record started about 4 or 5 years ago, and that it was looking at a platform that took a copy of data and then made it accessible back out again. So they've done some great stuff there in terms of, for example, they've now got an API marketplace and a developer portal sitting across the top. They've certainly grown the use. The key difference would be that our premise is that we don't need to consolidate all the data as our fundamental architecture. We think it gives us more flexibility and more value for money if we just use data where we can get it, as long as it's trusted. Yeah.
Wonderful. Right. And I think we're going to have to probably draw it to a close there. I just want to say thank you so much. It's been incredibly useful and informative. From the questions that we've had, we can see that we've had some really good engagement, and I can see that, and I'm sure Ruth will be able to coordinate some answers to those questions from yourself, Darren, perhaps back out in an email to those that registered for the webinar. So Ruth, do you want to make a quick comment?
No, just once again to thank you, Darren, for your time, and to remind people the webinar is recorded. Darren's offered to share his slides, so you will not miss out, and we will make sure that the rest of these questions get answered. Thanks very much.
Great. Thanks, everybody. Thanks for tuning in. Thanks, Darren.
Thanks, everyone. Thanks for the opportunity.